It's good to have you again, Dr. Ben. There was a gathering of health professionals today in a dialogue session. What was it about?
Well, the Delta State Contributory Health Commission has evolved since 2017 when it commenced till date and has achieved quite a lot. Most significant of it is the fact that we have the highest number of health insurance coverage amongst all the states in Nigeria, particularly a significant coverage for the poor and the vulnerable residents of Delta State. In view of that, UNICEF has taken interest in the achievements of the Commission, done a research review on it, and has seen that most of our service delivery processes are comparable to service delivery processes of other notable countries that have achieved universal health coverage. So with that mindset, we know what has happened in Rwanda, Malaysia, the Philippines, and other countries that have achieved universal health coverage. So UNICEF, having that realization that our systems and our processes are kind of in line with what those other countries have done, have seen that Delta State is on a good pathway and a good trajectory towards achieving universal health coverage by the year 2030. So with that, a position paper was initiated to be developed for putting out what the Delta State model is, doing a peer review report on it, and that position paper is ready. And UNICEF also felt that before they take on that position paper as a model for expanding universal health coverage in Nigeria, that was good. They get in expert policymakers, the private sector, the service providers, basically getting a stakeholder policy dialogue session to review that policy paper, position paper, critique it, analyze it, and look at all the various dynamics and dimensions of enhancing universal health coverage, particularly ensuring that the demand-side health insurance system and the supply-side healthcare provider system interact for the benefit of residents of Delta State. So today's policy dialogue session is to create that opportunity to critique, analyze, review, and come up with a more cohesive, a more dynamic position paper that UNICEF now intends to use for its expanded advocacy program for achieving universal health coverage in Nigeria.
Speaking of interaction with UNICEF and other countries and their health scheme, what is the outcome of those interface? And if I may, what impacting module has that precipitated?
Well, some years ago, when we were starting over the scheme, we developed our strategic implementation program. It had a startup phase, it had a consolidation phase, it had a sustainability phase, and it has a continuity phase. We have gone through the startup phase, we have gone through the consolidation phase. We are just rounding up the sustainability phase, and then by next year, we'll start off the continuity phase. But at that early stage, UNICEF took a team of from Delta State that comprised the Commissioner for Health, setting the primary healthcare agency, the Commissioner for Economic Planning, and the chairman and the DG of the health insurance scheme. And we went to Rwanda to study their health insurance system. And it was interesting to note that there were comparable attributes, and there were even some of the attributes which we had done that was adjudged to be quite advanced and quite remarkable. And based on that, when we got back, the Rwandans said, that they would also like to come visit us to have a study of what we're doing. So it's more like a peer review system. And based on that, UNICEF noticed that we're also advancing in terms of our quality service delivery, in terms of our ICT, most importantly in terms of the outcomes of our services. So based on that, they have looked at it and said, there are certain things that can be done, that can be put in place so that we can now start creating models that are replicable. UNICEF has actually sponsored some other states to come understudy the Health Insurance Commission in Delta State, and it becomes a model for them to adopt. So it's normal a case of everybody going from Nigeria to Rwanda to study. People are now coming to Delta State to understudy, and the Rwandans are also saying, hey, we might need to come to also have a peer-reviewed discussion, also study and get some lessons from what you've done. So that is why UNICEF took up what we have done here and took it up in comparison with what has happened in Malaysia, Rwanda, Philippines, and then crystallized it into lessons learned, and then also come up with the recommendations that can enable Nigeria be positive in its trajectory towards achieving universal health coverage.
Let's come back to today's session. Majority of the discussion today were centered on strategic purchasing, demand and supply of health service. As the advocate of the enrollee, what are you doing to ensure, since the demand side falls squarely on the commission, what are you doing to ensure effective service to the enrollees?
So the health insurance program basically demands healthcare service on behalf of the people. And that demand is implemented through a purchase of healthcare services from the healthcare providers. So that is why the health insurance is the demand side, while the healthcare provider is the supply side. So the health insurance registers people into the scheme using the ICT or whatever dynamics that is required, get the people to choose the facilities they want, and then they send the names of these enrollees to the facilities with a capitation upfront payment, basically telling the providers that have been accredited that we're giving you this number of people, we're demanding this quantity and quality of healthcare services on their behalf, we're paying you an advance money for them whenever they come, and please provide them with this healthcare service that have been demanded that they need, and then also send us a bill if the service is beyond the capacity requirement of what the capitation is to cover. So that now comes back as a fee for service payment. So that is the dynamics of it. The providers now get their facilities ready with the upfront payment given to them. So they're supposed to ensure they have the right stock of drugs. They are supposed to ensure that they have the right personnel. They are supposed to ensure that their infrastructure is optimal and that their service delivery processes are okay. That is why they have received an advance payment to prepare for the patient to come. So when the patient now comes, they provide the service and then they can send an extra bill. And that is the supply side. So initially, we met a system where the hospitals were used to a patient walks in, they treat you however they can, and then they send you a bill. And there was no real emphasis on what quality of care have been given, what standard of care has been given, how satisfied is this patient to this care. And that has been what has been happening. And we had to initially adapt to that because there was also the challenge of the hospitals, the healthcare providers, to first of all even understand what are the rudiments of a health insurance program and their capacity to be able to optimally deliver. So there was some basic delivery capacity, but it wasn't very optimal. So over the years, we have built that capacity through funding, through training, through capacity enhancement. So that early phase where we were paying for services rendered or just paying money and there was no clear-cut emphasis on the quality, the standards and all that, is the era of passive purchasing. So let's give an instance. So the Ministry of Health provides grants and funding to hospitals to prepare for patients. That is also passive purchasing. So the Ministry of Health had a passive purchasing arrangement with the providers. The health insurance started with that. Now, over the years, we realized that we have come to a stage where we can now hold the hospitals properly accountable for the quality of care. Yeah, because we've seen situations where our enrollees come and tell us they went to the hospital is locked up. Or enrollees go to the hospital and they tell them, go and buy the drugs, when the hospital has actually collected an upfront payment for that service, or the service is not adequate. Actually, in our health insurance program, every patient is supposed to sign at the end of the service that he's satisfied with the service delivered, but that is not properly being complied with. So we have now realized that for us to be able to create a continuity of the program beyond where we are, we should start institutionalizing our processes, start ensuring they are well entrenched, they are well backed up and formidable to be able to stand the test of time. So that is why we are now starting off the strategic purchasing arrangement. So in a strategic purchasing arrangement, you will not receive an enrollee except you have the capacity to provide that care. Unlike in the passive purchasing, where the enrollee just chooses a facility without even knowing whether that facility has the capacity to provide care. So in this one, the enrollees don't just choose any facility. They will choose a facility based on the service capacity of that facility. I give an example. A facility that does not have a surgeon cannot receive a surgical patient. A facility that does not have a pharmacist or a pharmacy technician cannot be saying it's going to treat patients and dispense drugs, because what drugs, who is checking the quality of the drug, who is making the requisition? You understand? A facility that does not have a lab technician or a lab scientist cannot say he wants to provide lab services. No. So we are now going to categorize every hospital based on their service capacity and capability, and we will contract with them in view of that. So we will not contract you to provide a service to our enrollees if you don't have the full complement of the healthcare service requirement. If you don't have it, then we'll accredit you only to the capacity you can provide. Like I give an instance, our primary healthcare centers, they are not all at the same level, but they are spread across. And we don't want to disenfranchise people in the disadvantaged part of the state. So we've accredited the primary healthcare centers, but we've turned them into level 1, level 2, and level 3. So level 1, which is the baseline, is that you must have as a minimum a health assistant, a community health extension worker as a minimum. That means that that person can actually see a patient, take the blood pressure, take the temperature, check all the vital signs as a basic minimum. But that facility cannot provide any service beyond what a community health extension worker is recognized to possess. So automatically you have to refer to another primary healthcare center that can provide a higher level of care, which is now level 2, or you refer straight to a secondary healthcare facility if the service requirement is a secondary healthcare service. So for everybody that receives a patient, you provide a basic care. If the care is beyond your capacity, we will know, because your certification will show your final level of care. And you're supposed to confirm from the commission and then refer to the next level of care. So level 2 are the facilities that can provide the standard care. Now, we're even seeing situations where a patient requires secondary care, but the secondary care requirement is basic. Probably he needs a high level of drugs that needs to be covered under secondary care, or he needs just a day or 2 admission, bed rest and all that. It won't be fair to refer that patient to travel for hours or 30 minutes and go to another facility to rest for 2 days. So we have categorized level 3 facilities within every local government or within every catchment area, that the executive secretary of the local government health authority, who is a medical doctor, will superintend over that facility. So such facilities will give them level 3, so they can do some basic secondary care service for the benefit of the patient. So the patient doesn't need to travel travel far to get secondary care drugs or for 2 days bed rest. So those ones are secondary level 3 primary health care accreditation. Same for the secondary care. We have level 1, we have level 2, we have level 3. So level 1 secondary care facilities are the ones that can provide just basic secondary care. A level 1 secondary healthcare facility cannot perform surgery because they obviously don't have a surgeon. They probably just have a medical officer who is just going to provide basic routine healthcare and a few days admission and all that. While a level 2 will actually now have the gamut of service delivery capacity that can take care of the requirements in the benefit package. Then there's level 3. Those are the ones that will have, we call the Center of Excellence. I give an instance. Level 3 facilities are facilities that will have a consultant obstetrician and gynecologist who will be an expert in cesarean section. So that in that way, all cases, cesarean section cases, or pregnant women that need cesarean section, instead of them being handled by people that are not really qualified, they are all referred there for that kind of service. So I'm just giving an examples of our various processes. So those ones are level 3. So level 3 facilities are the facilities that have the absolute capacity in terms of personnel, infrastructure, and the system to provide that level of care. Level 2 has the same thing. Level 1 has the same thing. So we believe that if we create this platform, at every time, our patients will be assured of getting the quality healthcare service they deserve within that scope of service system. But once beyond that, instead of them dabbling with the patient, they must refer. So a facility that does not have adequate stock of drugs should not bother treating the patient and writing prescription for the patient to go buy outside. Just refer the patient to the next level of care where those ones have the adequate stock of drug, because that is why we keep having the issues where the commission is accused or harassed over, oh, I went to the hospital, they didn't give me drugs and all that. No, we're trying to see how we can resolve that. So we will not accredit a facility that does not have a proper pharmacy, so that the issue of there's no drugs now, they just refer. We have also said that for the patient movement from one facility to the other, the facility will be responsible for the transportation. So for you to be a level 3 primary healthcare center, you should have a patient transport medium to go pick up the patient to your facility. If you're on water, there should be an ambulance service or patient movement service. Same thing, if you're a secondary healthcare provider, you should have a way of picking up your patient. So it's not a case of you tell the patient you have been referred. The patient now goes to the road, probably is not feeling well and is now looking for how to enter a transport system to go. I mean, the life of that patient could be at risk within that transport period. So it's also part of our strategic purchasing program that facilities that are supposed to receive patient takes the responsibility for picking that patient from the point of referral to the receiving referral point, so that the patient's life all through the treatment cycle is protected and covered by medical personnel services. So that's basically what we're also trying to do, differentiating between the passive purchasing and the strategic purchasing. And we will only pay a facility for service delivered. So if you send us a bill from a level 1 primary healthcare center that you provided 2 days bed rest, the question is, you were not accredited for that. You should refer. That bill will not be paid. Or a level 1 secondary facility telling us that he did a cesarean section. No, it's not going to work because you were not accredited. You haven't shown us the capacity that you can deliver that quality level of service. So that's basically what we're trying to do. It's going to be ultimately for the benefit of the patient, and it's going to be also be a challenge for the healthcare providers, especially the government healthcare providers. So we're also carrying out a capacity building workshop for them to capacitate them on the rudiments of bookkeeping, on the rudiments of health insurance, financial management, on the rudiments of what strategic purchasing is, how they can do their drug requisitions, how they can ensure they have adequate infrastructure to provide care, how they can manage their personnel system. So all that capacitation is what we're doing with an extensive training. After the training taking place at our various training centers, we will also now send the team that are going to be visiting these hospitals to be sure that the training they've received, they continue to apply it in case they've forgotten certain things, because we give them a handbook that they can always refer to in case they need to refresh their memory on certain of the requirements. But a team will also go around, be following them up, be sure that they are doing the right thing in the right process, they are following the right protocols, and they are abiding and adapting to the new requirement. If we find a facility that is having the challenges of being able to keep up, we will now put people on ground there to do hand-holding for a period of 3 months, 6 months, until that capacity is enhanced. So all that is what we're doing also, to just not set up a policy, come up with a program, but also capacitate them, train them, and follow them up to be sure that they are able to meet this service requirement for the benefit of enrollees of the scheme. And the also important point is the fact that the health insurance program is not a healthcare service program. We are a healthcare financing program. We don't deliver clinical service. We don't dispense drugs. We don't provide any surgical service. We only financially capacitate the facilities to be able to treat our enrollees well, properly, and with the right standard. That is why there's a supply side and there's a demand side. We demand healthcare services on behalf of enrollees. The supply side supplies the healthcare services we have demanded and that the enrollee needs, in line with the agreed templates, protocols, and service level agreements we've gone into.
There were discussions around private partnership during your session. What's your disposition or inclination towards this?
Yes, so the issue of the private sector involvement, it's not to take over the functions, actions, and responsibilities of the government facilities. So what has happened is that when we came in, we visited every primary healthcare center in Delta State, all of them, about 420. And we realized that there were a lot of facilities that were built up and locked up. No nurse, no chew, nothing. Completely locked up, overgrown by weeds. And surprisingly, these facilities are in locations that have no alternative. I always give a very good example of Polobubo and Oporosa. Polobubo is about 3.5 hours by speedboat from Warri. Oporosa is about 3 hours and 2 hours 45 from Warri. And when I heard that there was no facility providing care in that entire Gbaramatu kingdom, I was a bit surprised, because it's a very formidable environment. So why don't they have service? And I was told, oh, there was this facility that was built 20 years ago and has been locked up. And I'm like, why? So we took a trip there and we saw it. And we realized that the problem is this: the government workers have a condition of service that is applicable to everybody, without understanding the dynamics of the peculiarities of certain regions, that general condition of service is not applicable there. I have an experience in the oil and gas industry, and within the Gbaramatu Kingdom and the Polobubo environment, there are several oil and gas facilities there. And the oil and gas providers are able to provide healthcare services to their people. So if they're able to do that, then there should be a way to also provide healthcare service to the people that live there. And that's why organizations like Chevron has magnanimously built up the facility. The question now is, how do you operate it? So we realized that there was a challenge for the government system to be able to do that. And the Pharmacist Foundation, the partnership with the Dutch government and the Bank of Industry and us, we sat down and said, what's the best approach to it? We said, well, we adopt the access to finance model. And what does it say? Most of the oil and gas facilities have contracted their healthcare service to private providers. So the private hospital sets up a team of doctors, nurses, medical lab sciences, pharmacists, cooks, laundry, everybody. A complete ecosystem of healthcare service delivery capacity. And they do back to back. 2 weeks in, 2 weeks out, 2 weeks in, 2 weeks out. While they are there, the doctors are providing care. They don't have to worry about what they eat because the cook is going to make their food. They don't have to worry about their clothes because the laundryman is going to wash their clothes. They don't worry about security because the place is secured. So everybody works as a team. They take 2 weeks, they take out 2 weeks, and they rest. So we realize that if we adopt that system by ensuring that we contract reputable private hospitals who have the experience of providing this level of service to the oil and gas industry, that if we do that, it will work. So we advertised and they applied and they were vetted by the Bank of Industry and the Pharmacists Foundation team, and we went into a collaboration to provide them the financial resources to guarantee them going there, because they look at it from a return on investment portfolio point of view. But the issue is this: we have private hospitals already contracted into our health insurance scheme. So they are not strangers to us. We already have a reporting, a financial management system relationship with them. So we said, okay, this government hospital that has been locked up and abandoned, can you go there using the model you use for the oil and gas industries to provide healthcare services in those places? We will guarantee you the patient load, because we're going to register everybody in that community into the health insurance scheme, and we will pay you with the same financing model that we're using to pay other accredited facilities of our scheme. And that is just what we did. And the facilities the providers were quite happy about it. So we give them a seed fund, and as they treat, we'll recover the resources we've given to them. So we capacitate them with the seed fund. They are credit worthy, they guarantee the loan they are receiving, and the Bank of Industry manages the financial processes. Pharmacists follows them up to ensure that the standard of care they've been contracted for is what they do, and we take on the responsibility. So the PPP program is not just calling private sector. Everybody has a role. The Bank of Industry in the PPP program provides the financial modeling, evaluation, and confirmation, and they loan out the money and they get the return on investment to ensure that the finances are properly managed. Pharmacists provides the business plan, the programming, and then the quality of healthcare guarantee to ensure that the service delivered is actually of the optimum standard expected. While the health insurance scheme now registers the people pay premium. We pay the financing to the provider, telling them that we're sending these people to you, this is our seed fund for you. If you provide this quality of care, we will pay you this amount of money. So that is basically what the Access to Finance PPP program is. So it was easier for us to start that off with the established systems, with the private providers that have the experience, with the private providers that have the capacity to do it, with the private providers that are willing to take that plunge. And that has been a success, because facilities that were abandoned for 20 years are fully operational using the same model. The oil and gas companies are now contracting those facilities to receive care, and because it's a lot cheaper for them. In fact, recently Chevron said, oh, this is one of the best hospitals in the entire Baramatu Kingdom now. So instead of us equipping our own hospitals, we will now continue to equip that facility to meet our service delivery requirement, just in case we have any serious emergency within our oil and gas installation. Instead of ferrying the patient to Warri, we just take the patient just across the water to that location. So everybody is benefiting, everybody is happy. So it's not like the primary healthcare agency is resisting private sector investment. What they're asking for is that just as we're capacitating the private hospitals to provide care, that we should also capacitate the government hospital service providers to be able to provide better care. That they are willing to provide care, but the financial enablement for them to be able to deliver is where the problem is. So that is why we're also engaging them. Like I give an instance, all our primary healthcare centers are ICT enabled. And it's amazing to see the matrons, the nurses talking about download, synchronizing data. They even know the terms, and they do it. We just support them remotely now. We initially were doing hand-holding, but they can operate the ICT system. So they see patients electronically, they do their bills electronically, they check all their services, delivery requirements electronically, and they synchronize and transmit to us. We just receive it on our data center, analyze it, confirm, and we just credit the account with payment. So the entire process is seamless. And that shows that they have the capacity to meet up if they are capacitated. So we are currently now looking at extending that access to finance program. So like when we spoke to Bank of Industry and we said, can we extend this to the government-run hospitals? And they said, oh, the problem is, are they credit worthy? Can you guarantee payment? And what do you need? Of course, if you want to go take a loan, they will ask you for documents, your corporate affairs commission, your bank statements, and all that. Most of these primary healthcare centers don't have it or did not have it, but we've capacitated them to be able to have a bank account. We pay the money directly to the primary healthcare centers. The nurses are responsible for dispensing the money and managing it. So there's a cash flow report that a bank can look at and say, this primary healthcare center receiving this amount of money. How are they spending it? So they've covered that aspect, that financial management. The next thing is they don't have certificate of incorporation. We said no. We have analyzed them. We have accredited them. We have given them a certificate of accreditation. That is a recognition. Because it's the same thing. What's a certificate of incorporation says you've met certain standards to be recognized as a company in Nigeria. Our certificate of accreditation says you've met this standard to be recognized as a caregiver in our scheme. And that is it. We signed a service level agreement to them that defines the boundaries and the requirements and the expectations of the service delivery pathway. If you provide this service, we will pay you this amount of money. If you provide this quality of service, we will do this. And it's signed by both parties. So we explained to them that these primary healthcare centers, these government facilities have met all the credit evaluation requirements. The only issue is that there's no managing director and all that. We said no. Right now, the head of the facility is the business owner. He's the business owner of that primary healthcare center with expected deliverables, with expected KPIs and all that. And they are willing to do that. And it's interesting to know that the discussion with the Bank of Industry is an advanced stage where we can actually deliver that access to finance program to government-run hospitals so that they're dependent on government for money to operate is no more. The health insurance scheme, like I say, is an organization that has the responsibility of providing healthcare financial support and management, not healthcare clinical service. We don't do clinical service. We just create a healthcare financing enablement to help facilities provide quality healthcare services to our system. So that is actually the issue with the PPP. The PPP is not that PPP is bad. No. As you are capacitating the private providers to run government defunct facilities, also capacitate the primary healthcare centers, the government-run facilities, to also provide service under the scheme. And we believe that with that understanding, we'll be able to achieve a revitalized primary healthcare service in Delta State.
In sequence, this seems to have been the strategy that has been unfolding from the get-go. A lot of them I want to believe that a lot of this has not been in the public domain as much as is possible. As we are looking at the strategy towards the implementation and the adjustment of policies, would you say confidently that there was a deliberate strategy to keep certain things contained while the process is ongoing?
Yes, you will say that because you see, you don't start jumping around that you can deliver on a service when you have not even capacitated yourself to deliver. So you are putting the cart before the horse. So like I said, we had a strategic implementation program. It spanned 8 years. That this stage, this is what we'll do. This stage, this is what we'll do. Now let me give you a typical example. Before we started, we had meetings with all stakeholders, Okada riders, market women, plumbers, carpenters, doctors, pharmacists, lab scientists, bank staff, the organized private sector. We had meeting with everybody, and what we were asking, we want to start a health insurance scheme in Delta State. What do you want? What services do you need? How do you want it? How will it work? And that helped us develop the benefit package. Our benefit package, we didn't just wake up and write it. It was a collective agreement from all stakeholders in Delta State. When we finished developing, we brought it back to them, and everybody looked at it and signed it off. Like I tell you, the Okada riders were just interested that if they break their leg, will it be treated? And we said yes. The market women were interested in, would they give them medicine for blood and typhoid? We said yes. Everybody had its expectation and requirement. We also now did a baseline assessment study to determine if the hospitals, the healthcare facilities have the capacity and the capability to provide this care that is going to be demanded. We had interactions with them and they said yes, if this funding is provided, we'll be able to meet up. We also had interactions with the social organizations that we need to identify how many people in Delta State will be unable to pay for health insurance. We cannot leave anybody behind. We also accommodated that. That determined our baseline assessment study. With that business assessment study, we now determine how we're going to roll out. If you recall, the program started with pregnant women and children under 5. Why? Because they were the most vulnerable people in the society. Immediately we finished with them, we started with the civil servants. After that, we started with the informal sector and the organized private sector. Reason is that in a health insurance program, you practice what they call cross-subsidy, where you get the rich and the poor into the pool, you get the very sick and the very healthy into the pool. When you mix it up, that is what gives you the ability to deliver a health insurance service. If you don't do that, if your enrollee base is mostly the poor, your health insurance will not succeed. If it's mostly the sick, your health insurance will not succeed. If it's mostly the rich, your health insurance will also not succeed, because the rich people occupy just a small percentage of the population. So we must get everybody into the system. I give another example. From day one, we planned to use ICT. But when we did the service capacity analysis, we realized it was impossible to deploy ICT across board because the people did not have the basic idea. So what did we do? We started with manual and transitioned into an ICT system, where the ICT system is now formidable. If we came from day one and told the nurses in the primary care centers you must use ICT, they probably would not have taken it. It took us 2 years to encourage them, support them, and capacitate them to start using ICT. We also realized that even if you deploy the ICT, where's the light? We had to get the ICT system that is solar powered, and we deployed solar to all of them. So at every stage we had a plan. At every stage we had an intention of what to do and what to come out. So not everything we could say from day one, because I know a lot of people said, oh, but you're not talking about your health insurance scheme. We said, no, we will talk about what we can do. We won't be talking about what we cannot do. So what did we do in the first talking about situation? We talked to them advocacy. It got to a stage we had a meeting with the President General and Secretaries of all towns union in Delta State. At a point, we had a meeting with all traditional rulers in Delta State. We met them at the various senatorial districts. At one time, we had a meeting with Okada riders in Delta State. We had a meeting with the Civil Service Organization, Trade Union Congress, Nigerian Labour Congress. We had interactions with them. So at every stage, we sent out the message that was adequate and required. Now, there was also another thing. If we had done advocacy, and a very serious and elaborate advocacy, and we're able to pull in 2 million enrollees, where are the facilities to provide the care? We would have overwhelmed our healthcare service system. So we always graduated all our actions and activity to be commensurate with our capacity to deliver the service required. Because if you take on too much, like they say, if you bite more than what you can chew, you choke yourself. So we had been very strategic. That is why we have come of age now, where we can actually come out and say, yes, we're ready now to do the elaborate advocacy. Why? Because we have a formidable ICT system. 2, we have a financing model to capacitate the healthcare providers to provide care. 3, our operations have become well entrenched, where we can absorb whatever requirements it is to provide care. Those are the things that are there for us to do, and that is what we have been doing, ensuring that we're able to provide the care that is guaranteed, and we talk about what we can provide. So it's a stage process, is intentional, right? So we won't say we haven't done advocacy. We'll say we have done the advocacy required for each moment, I mean, here I am granting a formal press interview. It was difficult for me to do that previously because if you ask me now, okay, how many enrollees do you have? And I tell you I have 2 million enrollees. You tell me how many accredited facilities can provide care, and I say 50. You'll be wondering what am I talking about. But I can tell you now that we have about 480 something or 490 accredited healthcare facilities across the state in various capacity. So I can as well tell you that I'm also planning to have 2 million enrollees because I have the healthcare providers to provide that care. If you ask me how am I going to achieve the 2 million, I cannot tell you about my advocacy program, what I'm going to do, the commission is going to do and all that. So that's actually what we have been doing, ensuring that at all times we are doing what is adequate, what is required, and what is capable.
You seem to have got acronym from universally. Attention has been all over the place. States are going to see that as a template. Despite the challenges, what do you think has gone into all this to make all this happen?
Well, I can tell you straight away, is the political will of the governor. He's been very formidable. He's been very on point, and you know he's a master of this game. He was in the National Assembly and he achieved the National Health Act and also enhanced the capacity of the National Health Insurance Scheme to provide a formidable health insurance program across the country. When he was commissioner, he advanced primary health care service. In fact, I don't know if I'm very correct, but I'm sure during his tenure as commissioner, every primary healthcare center in Delta State had an ambulance. Every primary healthcare center in Delta State was capacitated. So he has that drive for primary healthcare and rural healthcare. And there's one thing people don't almost realize. When he graduated as a medical doctor, he did not go to Lagos. He did not go to Abuja. He did not go to London. He went to a village to start up a rural primary health care service. That is formidable. So you could see that he's always had that interest for rural care, primary care, quality care that is to the benefit of the generality of people. That strong political will, the capacity, the foresight, the planning, the integration into his entire program as a governor is what has actually led us to this success.
In summary and in clear terms, Dr. Ben, is the Delta State Contributory Health Commission ready now to deal with the healthcare needs of Deltans and residents of Delta State?
We could say yes, not that we have the capacity. We have come of age. We have been able to show evidence, success story that people are now interested in supporting us. So we have a robust relationship with the House of Assembly. They are willing to appropriate adequate funds. They are willing to do oversight function, effective oversight function on both the commission and the healthcare providers. And they've been very supportive of both the supply and the demand side, trying to ensure that we get what we need. They advocate for us. It's a very mutual relationship. I was with the chairman of the House of Assembly. He said he wants to go with us on a field monitoring team. That is formidable. The appropriation committee always come to us. Your resources, how are you using it? Is it adequate? Are you managing it well? What can we do? So we have that strong support. The governor calls us regularly. What are the challenges? How can we resolve it? Economic planning, we have a fantastic relationship with them. With the Ministry of Health, we do. In fact, we had a joint board meeting of the Hospital Management Board and the Delta State Contributory Health Commission. Two boards sitting in one meeting as a joint meeting with two co-chairmen. What were we doing? How do we work together to resolve challenges and ensure we continue to progress? We're doing the same thing with the primary healthcare agency. So now we have come with it. People have come to see that it is the way to go, and we're getting that support. The Commissioner for Health is formidable. We have meetings with him regularly, and he always says it. The health insurance scheme must succeed. Everybody must support the health insurance scheme to succeed. So we thank him for that. We'll continue to work with him. The Permanent Secretary, Ministry of Health, is a member of the board of the commission, and he supports us. We have an elaborate relationship with Labour. When we started talking about the issue of some healthcare workers not meeting up with service demand, Labour said set up a committee. So we'll have a Labour monitoring team comprising of the Nigerian Labour Congress, TUC, Nurses Association, Nigerian Medical Association, Judge Consult. They form a team and they go around going to talk to these hospitals on the need to enhance and improve their behavioral tendencies towards the patient. So I can list all of them. So saying that we can meet up with the challenge is not just our capacity, but because of the support that we have to be able to overcome and resolve those challenges.
Thank you for seeing how that all this stands out. Thank you so much for your time.
Thank you very much.